Awesome. Thanks very much for the kind introduction, Dr. Chow. As he mentioned, topic of the discussion today is really about Takotsubo, also known as stress cardiomyopathy. Nothing to disclose, absolutely no financial disclosures. Would love some. I have probably met most of you, but if I haven't, I'm one of the PGY5 cardiology residents here, and I'm just here for my echo rotation. So briefly, the objectives for today are to reduce the incidence, that really the epidemiology of Takotsubo's cardiomyopathy, as well as the pathophysiology, which drives it. In that, hopefully review the role of TTE in the diagnosis, but not just the diagnosis of classic, but also the atypical variants of Takotsubo's, in addition to how TTE can be used in management, specifically detection of complications and mechanical complications of Takotsubo's cardiomyopathy. And then ideally, we'll have some time over and we can go over just a few of the cases that we've had here in this Echo Lab and just as a brief example. As to open it up, just to present a first initial case, this is Miss Cyrus. She's a 63-year-old lady. She's presenting with 3 hours of chest heaviness to the emergency department after a heated argument with her brother. Her medical history, is significant for hypertension and anxiety and GERD, not that much. She takes pretty much just amlodipine standing or regularly. Beyond this, she is a non-smoker. She does not drink any alcohol and really no sympathomimetic use whatsoever. There's no family history of premature coronary disease. And so if you were to take a patient like this in your brain and put them within that Diamond Forrester model of what is the pre-test probability of coronary artery disease or significant coronary artery disease leading to chest pain in this patient, the traditional Diamond Forrester models might put her around 50%. I just plugged that in this morning, so that's why I know it. The updated American and European models would argue it's more around 10 to 15%, still a relatively substantial pretest probability. The initial investigations, blood work, all of that jazz are relatively unremarkable with the exception of a high sensitivity troponin, which is mildly elevated. This is just the initial one, and an NT-proBNP, which is elevated as well at 1200. Upper limit of normal being around 300, let's say. The first chest x-ray, absolutely nothing on it. Again, would not be a cardiology presentation without an ECG. I'm not going to ask anyone to read the ECG. I'm going to read the ECG, but essentially there's mild ST elevation, J-point elevation in 1 and AVL, perhaps borderline in V2. You have some T-wave inversions of ST depression in lead 3. If you were just looking at this without any other kind of clinical history, you may say this could be an MI, absolutely could be an occlusive MI, almost follows a territorial pattern. It almost could be, for example, a diagonal or something like that. You're not sure. Because you are an academic cardiology staff, you have a cardiology resident in-house who is able to go down to the emergency department and take a quick POCUS. And in that quick POCUS, it looks like this. You're wondering why it's so shaky. It's because this is an actual POCUS I did, but then I took a video of the POCUS from my phone, which is why it kind of looks a little bit like this. But this is, again, maybe the quality of study you're receiving overnight if you're, the academic cardiology staff. From this, and just from what we know now, what we can say is we have someone with kind of a low to intermediate risk or intermediate to medium risk of pretest probability of coronary disease with ongoing chest pain, with ECG changes, troponin elevation, and a bedside ultrasound that looks like this. In terms of next steps, hopefully, again, I won't ask anyone, but I'll tell you what I did in this scenario for this particular patient. Again, a lot of these are changed, these details are changed to protect patient confidentiality, but similar case, I spoke with the interventionalist and we activated it as a coach STEMI. Now, obviously, the point of this talk is not STEMIs, so you know that it wasn't. The cath, I don't have a picture of the cath right now, but here's maybe, I can tell you that the cath showed non or minimally obstructive coronary artery disease. This is the LV angiogram afterwards, or the ventriculogram afterwards, and what you can see really is that apical and mid ballooning and that very, very hypercontractile basal segment. So My question then is this Takotsubo or stress cardiomyopathy? And obviously, it's the title of my talk, so yes, it is. However, before we go there, just to very briefly benchmark and say that there's still a differential here. You can have myocardial infarction with no obstructive coronary artery disease. The differential for that could include things like myocarditis, could include vasospasm, coronary artery dissection, or coronary artery emboli. So despite the fact that we have this very representative picture on both bedside echo as well as LV-gram, no obstructive coronary disease, and a very strongly representative story. I just want to caution people to not jump to conclusions here, and we haven't necessarily finished making that diagnosis. When we think about defining Takotsubo's cardiomyopathy, which I abbreviated as TTC for the rest of this talk, if this confuses you or if this stresses you out, good. There are a variety of different clinical criteria that you can use. Probably the most used, or one of the most used, is the Mayo Clinic criteria, which has been revised several times now. I'm not going to go in depth over the criteria, but briefly, it talks about transient wall motion changes in LV function, typically associated with some kind of stressor, the absence of obstructive coronary disease, new ECG or troponin biomarker elevations, and the absence of pheochromocytoma or myocarditis. There is a much more detailed, more updated ESC kind of European criteria for the diagnosis of Takotsubo's as well. Again, I'm not going to go through all of these things because that's not really the point, but the point is, even beyond this is also the Intertax international kind of Takotsubo's criteria for diagnosis, which is even slightly more complicated. What I want to focus on here is really just the core principles in defining what is Takotsubo's cardiomyopathy, which is, first and foremost, it is a diagnosis of exclusion. Again, meaning that you should have investigated and thought about everything else first before arriving to Takotsubo's as your leading and primary diagnosis. The second is that it's driven and characterized by transient wall motion abnormalities, meaning it has to recover. By definition, it should recover. And the last is that there should be some kind of ECG changes or troponin elevation, something to indicate that there has, in fact, been myocardial injury. Dr. Chow has asked me to present a few slides on the history of Takotsubo's. Dr. Connolly, I'm going to touch on in just a second. I didn't include a slide for you here, but what I will say is that one of my clearest memories is as a PGY1 internal medicine resident, having Dr. Connolly at the ward and him telling me a story about how he was this close to naming it after himself, and then got scooped by this guy over here, Dr. Hikaru Sato. So it was first described in 1990 by Dr. Hikaru Sato. He is a Japanese cardiologist and initially described this as a case series of about 5 cases, and he actually described it as stunning due to simultaneous coronary spasm. And so this is important. I'll come back to that later. It's based off of the Japanese word for octopus trap. So as you can see here, this is the left ventriculogram. This is what the heart is looking like in systole. This is, again, the complete akinesis of the apex and the mid-segments. And then you can see how it, again, resembles a Japanese octopus trap. How this octopus trap works is beyond the scope of this talk. It just looks like a pot to me. But it is apparently an octopus trap. So
it is actually important, though, as to why it gets the characteristic shape, because it's the neck which is smaller than the distal end, so the octopus can climb in and use its tentacles, and then it cannot get itself out because it doesn't know how then to convoluted body to get beyond the narrowing. So that's where the importance of the systolic image is, where you've got that sort of basal segment is hypercontractile and the distal segment is burned out. So it is actually important.
It is very important. Okay, good. Good to know. This was not high on my list of things to look up last night.
Yeah, it's totally irrelevant.
That's good. It's helpful. It's useful.
Totally useful fact.
I picked out some key quotes kind of from this case series just because I found it quite interesting. They described chest pain with ECG abnormalities matching symptoms of MI, but with no coronary artery stenosis. They described akinesis of the apical segments that we see on LV-gram and the diaphragmatic and anterolateral segments. So again, right over here, these two lines and these two walls right over there. And they also described the fact that it was transient and reversed within 7 days. Again, all things that are still very accurate and hold true for what we know about Takotsubo today, although obviously that understanding has evolved. To give a bit of Toronto context, because I think I know people like to do this, is it's actually been previously, an LV dysfunction has been previously described in non-cardiac illness even prior to this. In that case series, I think they had identified some stressors. In this case series, they actually just talked about, again, it's a group out of Toronto. Actually, it was done out of Toronto Western. And this was back in the 80s, 88, and they talked about LV dysfunction in patients with subarachnoid hemorrhages. And what they described was 4 patients who had akinesia, the apical and apical septum, and 2 of these 4 patients had ended up having LV thrombus, and 2 of these 4 patients ended up developing heart failure as well. So again, not quite the same context, mostly because these were patients who were hospitalized with something else entirely, what we now call kind of secondary Takotsubo's, as opposed to the primary Takotsubo's, which is somebody presenting with that chest pain. Still kind of interesting. Dr. Charles Taylor is a very famous neurosurgeon, for those who are curious. I didn't look up the other people.
Oh, yeah.
The other project is a cardiographer for Epidemiology,
Oh, excellent.
the former CSC president.
Wow. Okay, fantastic. I should have looked them up.
The paper on disappearing.
Really? Okay, so they're all very important. They're all
Now, these are all VIPs for our Echo community in
they're
Canada.
all VIPs in the Echo community. I probably should have looked this up again. Not wasn't high on my list of things to look up. Apologies. So in terms of the epidemiology of Takotsubo cardiomyopathy, it's relatively I shouldn't say it's common, but it's not uncommon, as we see quite a few that come through our Echo lab, 15 to 30 per 100,000 people per year. In the US and across Europe, this translates to around 50 to 100,000 cases per year. So again, it's not rare. You will encounter this. It makes up probably about 2 to 3% of suspected ACS cases. And in women in particular, anywhere between 5 to 10% of suspected ACS has actually ended up confirmed as Takotsubo's. Now, people have described in the literature increasing incidence over time. Whether this is truly increasing incidence or just we're better at diagnosing this and putting a name to it, I don't really know. I suspect it's more of the latter. But as you can probably also imagine, that this is probably still a diagnosis which is under-recognized and underdiagnosed, especially in places that don't have access to quick early angiography or great echoes like we have here. So the people who get it typically, most commonly, are people over the age of 55. So if you're a woman who's over the age of 55, there's a 5-time higher risk. Interestingly, there is not the same risk for men. So with men, there's no real age discrepancy whatsoever. And in fact, men who get Takotsubo's tend to be on the younger side than women who get Takotsubo's. Predominantly a disease of women. So the ratio is about 9 to 1. So 90% of people with Takotsubo's are women. Most frequently in postmenopausal women, and there's some theories about why this happens, but I won't go into that. And very frequently there's concurrent neurologic and or psychiatric disorders, whether that is epilepsy or anxiety, depression, or subarachnoid hemorrhages. There is more frequently something neurologic. So to go into the pathophysiology a little bit, you could talk for a long time about this, but just briefly, everything is kicked off with what is called a sympathetic storm. So this rush of adrenaline and catecholamines that comes. Now, we know this, or we think this, because when we look at patients with stress cardiomyopathy and with patients with just MI, and they actually measure the levels of endogenous catecholamines, so epinephrine, norepinephrine, things like that in the blood, as you can see here, and I'll just kind of point that out to you, it's almost 4 times higher in patients with Takotsubo. So again, it's not a strong association, but it's certainly a marked difference, which plays into the fact that these catecholamines are probably central and key to the pathophysiology. We also know this from incidence is like this. So this was actually an echocardiogram of somebody who was undergoing a dobutamine stress echo. Now, dobutamine, again, a lot of catecholamine and a lot of adrenergic activation. And this was somebody who, with the dobutamine stress echo, as you can see, has ballooning out of the apex. And on cath, it was actually negative. So again, it's little cases like this which give evidence and support to the idea that catecholamines, again, are central to this. There's also been a lot of animal studies, but I won't go into that. Now, something has to trigger this catecholamine surge. Very oftentimes, you've heard this described as broken hearts, so something very stressful. It's a very small graphic, but it's really a wide variety of things. It can be anything from the death of a family member to debt, having an argument with somebody, hearing good news even. It can be anything from an asthma exacerbation, a subarachnoid hemorrhage, cancer, or even hearing a cancer diagnosis that can trigger this catecholamine surge. In fact, in one large registry, they found about a third, and the way I like to think about it is a third, a third, and a third. So about a third were physical triggers, a third had emotional triggers, and about a third had no trigger identified at all. So that's also just something to keep in mind. These are just some case reports, but again, just some ideas of the things that can trigger Takotsubo. So this was Takotsubo's triggered by the death of cats. Takotsubo's triggered by, cosmetic laser treatment. Even happy Takotsubo. So Zumba-induced Takotsubo's cardiomyopathy, which again I didn't get into, but yeah, and for those saying exercise is good for you. There's also Takotsubo's post-birthday celebrations. In an international registry, for curiosity's sake, about 4% of people with Takotsubo actually had a happy event, celebrating something. So again, quite a significant population. So when you see your patient, ask them about happy things as well. Interestingly enough, from a population level as well, when we look at Takotsubo's, in Japan, they actually, again, where they study a lot of Takotsubo's, they looked at a large tsunami that came in 2011 and compared the incidence of Takotsubo's in the coastal areas affected by the tsunamis versus not, and found a marked increase. So again, just showing that we can see these changes also on a population level as well. This leads to a number of things happening from this catecholamine surge. One of those things is, do you have a question?
No.
Yes.
I think you said there was a slide that mentioned PO. I'm wondering if any of your reading you came across like POs, the instance more higher than PO.
Yes, it's a known thing in FIO, a known pattern of LV dysfunction in FIO, which again also lends credence to the idea that it's a catecholamine-driven pathophysiology. So the mechanisms by which the catecholamines affect the heart, a few different ones. One is multivessel vasospasm, and this probably presents or contributes something to the physiology. This was what was initially noted by Dr. Sato all those years ago. But what is kind of more, I shouldn't say relevant, but one of the more popular theories now is that it's really a lot to do with negative inotropic signaling, specifically from epinephrine. I'm not going to go into the weeds about this, but I will just say that I found this somewhat interesting and that there's a lot more of these, and may explain that pattern of Takotsubo's that we get, that there's a lot more of these particular receptors around the apex of the heart. We know the apex and the mid segments of the heart are more sympathetically innervated. And so epinephrine at very high levels is actually known to be a negative inotrope. At low to moderate usual levels of epinephrine, it's typically a positive inotrope. And so this may contribute to some of the changes that we see. Okay, with that boring stuff out of the way. The clinical presentation of Takotsubo's classically is very similar to ACS and really any other kind of cardiac presentation. It's chest pain, shortness of breath, palpitations, sometimes syncope. Just to highlight though that it can present with lethal ventricular arrhythmias as well, cardiac arrest, and as well as cardiogenic shock. The reason why I call this horses and zebras is just because I think if anyone came to you with this, you would think ACS, ACS, ACS a million times over. Takotsubo's, as I mentioned, by itself should get better. That is the whole point and part of the definition. Typically, recovery of LV function happens within 10 to 60 days. If you have late recovery, that's typically a bad sign and portends a worse prognosis, but it's also associated with older age, having more comorbidities. So perhaps that is why you have the worst prognosis. But at any rate, there is a difference in patients who recover quick and recover late. In one large case series, as you can see over here, by 60-day follow-up, probably like a majority of people had a normal EFs, like completely normal EFs. Takotsubo, and the reason why I included this slide up here is that oftentimes, and I think we're taught, or at least the historical teaching was that Takotsubo is benign. It's benign because it's transient by nature and it will get better by itself. That being said, complications are very common in the acute phase. And so again, in a very, very large international registry, they found that about 10 to 25% are complicated with LVOT obstruction and mitral regurgitation, again, from the same mechanism, which I'll show you in just a second. These people have thrombus formation, they have ventricular wall rupture, and they can even be complicated with arrhythmias, AFib being the most benign of them, but also ventricular arrhythmias as well. Anything from VT to polymorphic VT-VF. The in-hospital mortality, so the acute mortality, is actually about 2 to 5%. Curious if anyone has a good number for what the in-hospital mortality is for NSTEMIs. But my understanding is even in our modern day of taking care of ACS and NSTEMIs, with all the technologies that we have, the typical in-hospital mortality is still around that 2 to 4%-ish range. So just to say that despite it being called benign, it has a similar in-hospital mortality as having an MI. So again, just to take it very seriously. And lastly, and perhaps kind of most significantly for a lot of our patients, the recurrence rate is about 1 in 8 and studied over a long period of time. So about 12% of your patients, when you ask them, will this ever happen to me again? What can I do? You'll have to say, well, about 12% or 1 in 8, there's a good chance that this will happen to you one more time. There are differences now, and this is kind of emerging evidence, sex differences in particular. So when you look at men and women who get Takotsubo's, men tend to have worse outcomes, higher 60-day mortality, and even higher long-term mortality, all the way up out to 10 years out. So this is quite robust data. In the same study, when they used a matched cohort, meaning they took patients and tried to match the demographics so they had the similar kind of comorbidities, and so it was an equal apples-to-apples comparison, men and women, they found that while the long-term mortality was actually relatively similar, in-hospital mortality was still significantly elevated for men compared to women. So despite the fact that, and these were, again, men with a similar incidence of subarachnoid hemorrhage, similar incidence of everything else as women. So for some reason, it is more lethal. Okay. Now we'll talk about a couple of the different variants of Takotsubo's cardiomyopathy. So this is the classic variant. This is your apical type variant. I didn't really find, great still echo images, but hopefully you guys are okay with LV grams during echo rounds. This is about 80% of Takotsubo's. Very classic. I'm sure you've seen a lot of it. And then we go into the atypical variants. So this is what we would describe as mid-ventricular type. And so this is where the mid segments are entirely akinetic, and you have this kind of ballooning out of these mid segments with a hyperdynamic and hypercontractile apex and base. It's about 15% of Takotsubo, so it's the second most common type. The next type is basal type, or what's known as reverse Takotsubo's. This is one of the types that was actually initially described as being associated with subarachnoid hemorrhages in particular. It's about 2% of all Takotsubo's, and it's characterized by this akinetic, hypokinetic base to mid with a very, very contractile apex. Another type, and again, there's one more type after this, there's 5, but this type, the 4th type, is what's called focal. And this one is exceptionally rare, also hard to diagnose. You can honestly barely even see it over here. You can kind of make out the fact that this little segment over here is really just not moving at all, and it's really just a focal segment. I believe it's also most commonly along the mid-anterolateral wall as a focal point, however, not always. That's only about 1% of all Takotsubo's. And then probably the most rare is biventricular Takotsubo's. And so this is Takotsubo's that has any kind of pattern of LV involvement, but also has some right ventricular involvement as well. And that's really less than 1% of all Takotsubo's. Interestingly, as you guys can probably imagine, there was a study that looked at the ejection fractions of every single one of these variants. They're all relatively similar, and they actually all have relatively similar outcomes long term, with the exception of the focal, which tends to have a higher ejection fraction and do a little bit better, which you may or may not have expected. There are some additional echo assessments that one can do to investigate Takotsubo's. Again, I don't know if people are going to actually be doing GLS on Takotsubo's patients or suspected Takotsubo's patients. That being said, I found this interesting that you can see, again, that classic patterning where you can see that the apical segments are lengthening, not really shortening, actually. And this is on day 0. By day 6, you can see recovering by day 21. It's essentially back to normal. So these changes are present. And even if they are more subtle, by visual, they can be possibly better tracked and defined by GLS. So again, something to think about. Another interesting thing to think about, a technique that I'm actually not really familiar with, because I tried to look into how I may get this. I don't know if anyone, the echosonographers here, are familiar or have tried getting or know how to get distal LAD flow via echo. It is relatively complicated. I watched some videos on it and I still don't fully understand it. But the idea is, I don't know what that meant. Okay. Dr. Connolly's eyebrows. Yeah.
Yeah, but,
Well, pediatrics for sure,
yeah,
but for adult, it's difficult.
I think it's particularly popular in Japan. The Japanese investigators have done this mostly LAD. Occasionally, you get TDA flow. Essentially, it's Doppler.
Yeah. And so one thing I found kind of interesting is specifically in a variant and the apical Takotsubo's, if you're going to have a coronary artery that's affected, giving you apical Takotsubo's, it's going to be your LAD, and your distal LAD is going to be affected. And so their hypothesis was, can we assess the LAD? And what they found actually was that about they took about 56 patients total, 28 in each group, and they found that all 28 patients with Takotsubo cardiomyopathy for which they could see the distal LAD flow, all of them had distal LAD flow, as opposed to only about 10 out of 28 patients with MI, you could see this distal LAD flow. And these were patients who had relatively similar echocardiographic findings. And so more or less what they had said was, this is an interesting and perhaps a novel idea, although albeit very, very difficult technique to perform and perhaps not reliably reproducible, but it might differentiate between occlusive MI and Takotsubo's. And it might be an interesting way to do that. Okay, echo pictures. I can hopefully talk a little bit less. So the unfortunate part is that a lot of these pictures don't have much clinical context, mostly because the clinical context was no longer available on or through Epic. But just to start, this is an 82-year-old lady who presented to the emergency department with dyspnea. And there's no trick question here. This is quite classic, typical Takotsubo's, where you can see good normal movement of the basal segments. Everything kind of mid to distal to apical is entirely hyperkinetic / akinetic. I included this case really, sorry, I'm getting really distracted by this overhead thing. Yeah, exactly. Okay. The reason why. All right. Feels intentional now. The reason why I included this case was really just to demonstrate the phenomena of LV recovery. This is the exact same lady in exactly 6 weeks from her initial echo. You can really see that recovery there. And essentially the EF is completely normalized. All those wall motion abnormalities are gone. Okay. This is a second case. It'll be a slightly different variant. Somebody with subarachnoid hemorrhage. Can anyone guess what the variant is going to be? Basal. So it's a 27-year-old lady with subarachnoid hemorrhage, and as you can see here, it's the basal segments that are not moving very well at all, and the mid to distal apical segments are moving very nicely. We'll go through. And a lot of these, unfortunately, don't have follow-up images, but I would love to. This is a lady, a 69-year-old lady with acute chest pain who presented to the emergency department as almost like an ACS presentation. At first glance, you can already tell that there's something off just from the parasternal lungs. You can see that the basal segment's moving well, but the mid segments are not. A little bit hard to see the apex for sure, but you get the sense that perhaps something is moving down there. When you look at here in the apical forechamber, it's a little bit more obvious. This is the mid-wall variant of Takotsubo's. So this mid-ventricular segment ballooning with preservation of apical and basal function. And in fact, they again tend to be hyperdynamic. This is a 67-year-old lady, and there's a bit more to this lady, but she essentially presented with exertional chest pain and was admitted to RCCU as an NSTEMI. She was treated with antiplatelet agents pending a cath, essentially. This was the formal echo prior to the cath. So as you can see here, basal segments are moving quite well. The mid-ventricular segments are not, and you can't really see the apex too well here, but on the apical 4, you can look at this and say, well, this is quite consistent with the classic apical variant of Takotsubo's. Thanks for getting the lights. You can play this again too. And you might be wondering, why did he show us two of the same case? But it's because on further examination and with color flow, you can see a very eccentric jet of posteriorly directed mitral regurgitation. You look at the LVOT as well, you can see something else. Just systolic anterior motion of the mitral valve leaflets and obstruction of the LVOT. These were the gradients that were measured at the time. Valsalva was done as well. I'll say that by looking at the report, they reported it as a mean gradient at rest of 80 some millimeters of mercury. With a Valsalva, it was close to 100. Granted, there's a lot of MR, and who knows how much of that could have been contaminated and overestimated. But that being said, this is a case of someone who has still significant LVOT obstruction and MR, and overnight, and especially getting this echo prior to having the cath, this is the kind of case that can change your management strategy if somebody becomes hypotensive or anything else like that. These patients are often started as they come into hospital, maybe even prior to the cath, on afterload reducing agents, depending on what their blood pressure is, which may in fact exacerbate and worsen the LVOT obstruction. So again, this is to me a very clear example of how understanding the mechanical complications and the physiology here can be very, very important to management and guiding acute management of these patients and preventing some of that mortality that we see. Again, this phenomenon occurs because these basal segments are really just so hyperdynamic to make up for everything else that's akinetic that you get a lot of that sucking in, so to speak, and that's This one I have no clinical context for, but I thought it was an interesting case because it's not one that you see very often. This one you can see already right off the bat, she's tachycardic. You can see that the basal segments are moving, but everything kind of distally is not moving all that well. Is there anything else? Maybe I'll play this. Maybe I'll just leave it to the crowd, but is there anything else that kind of catches your eye here? It's one of the last variants. Yeah. So I think, anyways, I think I've to move on, but just to say that in this scenario, and maybe I'll give you the RV focus views first, or both these views at the same time. You can see significant epikinesis, akinesis of the mitral RV as well. So this is a form of, and this was somebody with clean coronaries, I think ultimately confirmed Takotsubo's with recovery of EF, I believe, but again, limited clinical history. But again, would be considered a very rare form of biventricular involvement in Takotsubo's. This is again another thing just to be very, very mindful and aware of, in that this kind of patient is not going to present as your chest pain gets better, does fine sitting on the ward. And this kind of patient presents in cardiogenic shock and is very, very unstable, may even need advanced therapies, mechanical circulatory support for a period of time, things like that. Okay, those are really my 5 hopefully interesting echo things. Well, I got them from the Black Book, so they're all interesting cases, as I've been told. A very brief amount on the brief touch on the management of Takotsubo's, really just to say that we don't have that much evidence on a lot of it. Acutely, we manage the acute things as they come up, and that's quite straightforward. But chronically, we don't have a good understanding of how we manage Takotsubo's moving forward. There's really kind of 2 things to think about. The first one is, do we have to do anything to make sure that the LV gets better? And how do we prevent the Takotsubo's from coming back? We have no good data to guide any of that. In one large registry, they looked at, essentially, this is retrospective data, but essentially they looked at patients discharged on ACE inhibitors and beta blockers, and they looked to see more or less mortality after 1 year if you were discharged on an ACE inhibitor versus a beta blocker. They found no differences in beta blockers, whereas they found a improvement or less mortality when discharged on an ACE inhibitor or an ARB. Now, again, retrospective data, it's hard to extrapolate, but the reason why we're so interested in beta blockers in this case is it's supposed to blunt that catecholamine surge. It's supposed to be central to kind of this pathophysiology, but obviously it doesn't work as it should. In another meta-analysis, which really looked at preventing recurrence of Takotsubo's, this is really just a big meta-analysis of a bunch of patients with Takotsubo's and who are on one of these medications, in this case, beta blockers, and seeing whether or not it actually helps in preventing the occurrence of this. And it, in fact, it does not at all. The odds ratio is 0.44. It crosses, the confidence interval crosses 1. And quite similar results for ACE inhibitors and ARBs in this scenario. All that to say, as cardiologists, and again, as the real cardiologists are sitting in the room here, we often discharge patients and prescribe ACE inhibitors, ARBs, beta blockers, because we think that it's central to the pathophysiology. It helps with neurohormonal remodeling of the left ventricle and should improve outcomes. But in fact, we don't really have any great evidence to support that. Again, I think it really just goes to show that we don't have a great understanding of all the different things that cause Takotsubo's yet. That is all I have for now. My major take-home points for everyone would be that Takotsubo's, while it's often preceded with a trigger, about a third of cases are not, so don't exclude it, even if you don't find that trigger. Takotsubo's is not a benign disease, and especially if you get to be that one to do the echocardiogram for that first person, identifying some of these complications, RV involvement, LVOT obstruction, significant MR, LV thrombus, these are all common complications and really, really important to touch on. And for echocardio and echosonographers in the community and things like that, looking for recovery is also very, very important as well, obviously. And just to say that we don't really have much evidence to support the chronic management and prevention. So use your best judgment and do what makes sense. I know that my typical practice and what I've always done has always been beta blocker and ACE inhibitor, because that just makes sense to me, as well as modifying if they have obstructive coronary, non-obstructive coronary disease, aspirin, statins, etc., and modifying risk factors. But I will also say that it's completely, now that I've looked at it last night, it is completely unfounded on most data. That being said, it does make sense. These are the references for the presentation. Thank you very much for your attention.
So thank you very much, Andrew. This is really great. It's a common problem that we face, especially when you're working in hospital echo lab. And for our community colleagues, you probably will encounter them when they recovered and then come to be followed in the outpatient environment. So today we actually have a very popular attendance. We have about 58 different groups or individuals signed on. So it's really fantastic. My question I'll start with is, now we have a lot of the GDMT or guidelines directed medical therapy, including ANI, spironolactone, all these kind of fancy stuff, Jardians with a bad LV. Should they be used? Have they been tried? Is that worthwhile? So do you have any opinion when you're reviewing this topic?
I will just say that what I've seen is, at least in the European guidelines and the best up-to-date knowledge, there's no recommendations given whatsoever for guideline-directed medical or usual heart failure guideline-directed medical therapies.
Good. Yeah. So that's helpful because not infrequently we actually see people coming back with it, and we don't know what to do with it afterwards. And also depends on which country they're in. Some countries they will do it, and so we're just stuck with dealing with it. So should they be on beta blocker for the rest of their life?
I personally would, I think. That being said, you can make the argument that there is no evidence to guide that statement, and you can also make the argument that there's more evidence now that even in MI with recovered LV function, there's not much evidence to support continuation and ongoing use of beta blockers beyond a year as well. So you could make that argument. The only caveat is that MI, unlike Takotsubo, or Takotsubo is unlike MI, has preponderance for recurrence in these individuals. I suppose MIs recur as well, but not in the same way that I'm referring to. And so that would be the only kind of vote in favor of continuing the beta blockers to prevent that. But maybe I'll open the floor to the experienced colleagues.
I think it's probably more heterogeneous. So, unfortunately, I think it's driven by anecdotes. There was
Andrew, just to say, I can't hear the comments from the room. People are too far from the microphone.
Can you hear me, Bob? I'm right beside the microphone.
Just barely.
Yell.
Is it on your computer?
Yeah, it's
Is it better now, Bob?
Much better.
Okay.
Thank you.
So I think the condition's probably heterogeneous, and I think many of us have anecdotes about it. There was a physician at St. Mike's who presented with classic Takatsubos, was treated with ACE and beta blockers, and discontinued at 6 months with normal LV function, who had recurrence. And so we ended up maintaining it. And I wonder if a component of them are like heart failure with recovered LV function. And there is data that ongoing therapy actually reduces the recurrence of LV dysfunction in the non-ischemic group. So I don't think there's a clear answer to it, but I suspect that there's great variability in the underlying pathophysiology.
Yeah, I think, when we look at the variants, I think a lot of the descriptive variants, one of the problems with the studies is we don't know the exact timing from the initial index event, and we know those catechol levels bounce around enormously. So some of the variants are, in fact, the traditional variant in recovery. So it's not again, it gets back to this heterogeneity. The in-hospital mortality, I would say, is unfortunately limited by old data from older studies. I think at that stage, people didn't diagnose SCAD and other issues on the angiogram, and they were labeled as normal coronaries, because I cannot think, and I was the first person in the world to describe Takotsubo outside the Japanese cohort, we do not see 2 to 5% in hospital mortality. The standard sort of end-STEMI mortality rate for clinical trials, which is falling each year, is somewhere around 4 to 5%. So that is vastly greater than what we see. Now, that's in a clinical trial setting, but it's not a huge difference there. So it's hard to see. So I think, unfortunately, the older data is limited a little bit by about some misdiagnosis. That being said, though, obviously the recurrence is a problem, and we don't really have good data. My only comment about medical therapy is if someone presents with heart failure, treat them with heart failure as HFrEF or HFpEF, and that would be the guiding principle, which would sort of come your Takotsubo diagnosis. If they've got heart failure, treat them as a HFrEF or a HFpEF as per GDMT, and then worry about things after the fact. But for sure, we've all seen thrombus formation, rupture, and other things. So it's, I don't want people to get the thought that it's benign. It's probably those and Hal and I were talking with comorbid disease, though, that you've unmasked another issue, and they're the ones who have a greater propensity for VT, AFib, and the other complications there. But it is very much driven by case report, anecdotal experience, and even if you look at the data in those registries things, they're all 100 or 6 or 4 people. It's retrospective data. We almost every time when we use retrospective data in medicine, we're burned. It's a problem. So I think you just do what you think is sensible and reasonable, and that's probably your best guiding principle, right? Yeah.
And I think if you have recurrence, you should stay on therapy.
Yeah, that's what I've done. Yeah. We had a case with Juan Carlos here. That was a lady who came in for a stress test, and during the stress test, I can't remember who was scanning, developed then apical ballooning, which we were worried was LAD disease, but the cath, and she was a postmenopausal woman who had the typical ECG changing and troponin rise. We capped her because we need to rule out epicardial coronary disease, but even a stress test can be scary, okay? So
treadmill or?
It was bicycle, so maybe that was it. She hadn't ridden a bike for a few years, so she was worried about falling off. Yeah. So the case series that I reported initially was a young woman who went to work, and her boss, she was a single mum, and her boss said, if you don't have sex with me, you're fired. So then she collapsed, and it was Takotsubo. She developed an LV thrombus. So she came down and I cathed her, and the LV was a classic, which I did not recognize what it was, and I put on all the drugs and sent her home. The next was a pregnant mum who was driving a car, and a car crashed into the back of the car, and she was pregnant, so we did an echo. And at that stage, we'd seen this other lady's LV improved, and it was like, it doesn't make sense, but we were worried about peripartums, scat, so we ended up capping her, and it was similar appearance again. And the third was during the Serb-Croat War, when two neighbours the husbands got into a fight, and the wife was watching this and trying to pull him, and she collapsed as well. So I called it sex, stress, and myocardial infarction and send it to the New England. And my comments back was, this is the worst case series I've ever read. And so then we sent it to Heart and the British Medical Journal, and then they published it, but they made me take sex out of the title because that was too racy. So it was immune syndrome stress cardiomyopathy. So there you go.
And you come across, like, there's an idea that I hear talked about occasionally, which is that we should favor carvedilol, the anti-alpha. But again, this is an area with limited evidence to begin with. So people sort of said that to me mechanistically, I understand why they say that, but is there anything that's actually looked at that specifically that you came across?
So I'll repeat the question, which was just that, is there any evidence to support the use of carvedilol, just from a mechanistic heart failure perspective? From what I've seen, no, there hasn't really been. And kind of the interesting part is why they think maybe beta blockers do not necessarily always reduce the recurrence is that for some reason, beta blockers have a differential effect on some of the beta agonist receptors. And for some time, while they can sometimes improve or blunt the response, they can sometimes also exacerbate the negative inotropic response due to epinephrine, which is possibly why you don't have as much prevention. Yeah. This is like the perfect conclusion to the talk. We found the patient. Everything is safe.
The only other comment I'd make is pathophysiologically, the pheochromocytoma is very different. So there's some data suggesting that you can avoid a cath and do an MRI and do T1 and T2 mapping as well as perfusion, and you can then avoid the cath. I think for the most part, it's easier to get a cath than an MRI, and it's practical and reasonable. So I don't know about that, but at a pathophysiological level, typically with the pheo or a subarachnoid, you do see contraction band necrosis. So it's actually very different when you look at it ultrastructurally at the myocyte level than what you see from Takotsubo. And that's different because it does drive different remodeling and responses in terms of reverse remodeling. But it's been very difficult to mirror in animal models and so on. So again, we're stuck with this anecdotal case reports and not any really useful way to help guide. But I mean, we see it a lot because of the we're the largest subarachnoid center in North America here, so we see a lot of the sort of apical sparing variants here. Yeah,
That's true.
I was gonna for acute management, and this is more in like the pheochromocytoma or the catecholamine cardiomyopathy from like substance abuse. We've had experience at McMaster with aggressive calcium supplementation, because there is like dysregulated calcium use at the myocyte level. I know they're studying that in Takotsubo, but one of the tips we had was that if there is like a noticeable hypocalcemia just from catecholamine surge, the patients respond very well to calcium supplementation. And in fact, with PHEOs, you put them on like a calcium infusion for management.
Chiming, a question is Bob. Just to be clear, basically, if you pick one of these up by echo, 100% of them should have a heart cath to study the coronaries.
Yep.
So if you're in a peripheral hospital or whatever, you need to refer these people for cath.
Yep, for sure. They all need caths to confirm they have Takotsubo. If they have coronary artery disease, then it's a different story. We have seen like people with large anterior MI with actually similar, echo wall motion findings. So sometimes it's hard to tell, just look at the echo image. It's almost like a diagnosis of exclusion sometimes, in a way.
Yeah. And maybe just to add on one last point to that, which is just to say that the new internet, like the INTERTAX group, actually recommends cardiac MRI specifically for that reason of as a diagnosis of exclusion. You have to exclude myocarditis because you have no clue if it is. And so obviously those resources are somewhat limited. Not everyone's going to get a cardiac MRI, but certainly cath or coronary CT as like a coronary assessment, I think is recommended up front from all the societies.
So I have a question for Dr. Leon Poi, if he's in the room. The question would be, would perfusion echo contrast imaging be helpful in this case? So now that you're going to echo the LAD, which can be done sometimes in very, very technically adequate patients, usually young and very thin. But how about echo contrast perfusion?
So I guess I would say that echo contrast perfusion, just like any other perfusion techniques like MRI or nuclear, is sort of a surrogate for coronary angiography if you don't want to do a coronary angiogram. You probably know there's been a few studies, usually relatively small numbers of patients with Takotsubo cardiomyopathy, Takotsubo syndrome with contrast perfusion. And for the most part, perfusion is well preserved in these patients. We did a few cases back in the 2000s for perfusion with some of these cases, and really perfusion is normal. So it kind of goes along with the normal coronary arteries in the absence of any true significant myocardial infarction, right?
Wonderful. I think it's coming up to 9 o'clock. So once again, thank you, Andrew, for this really great review and great discussion from everyone. And I really like the idea of using GLS. So maybe an ultrasonographer, if they see it again, do the GLS. It has a very nice pattern to it, and then we can try to observe these patterns using another way of looking at things. So thank you.
Thanks very much, everyone, for your attention.